Um, oh, we're going to start with Dr. Denis Nash, and he will give us his presentation, and then we'll follow that with our own Dr. Nina Yamanis, who will share her on-the-ground experiences working in implementation science in Tanzania. Let me start by introducing Dr. Nash. So Dr. Nash, it's a pleasure we've worked together. It's a pleasure to have you here in this capacity. So he is an infectious disease epidemiologist whose research generates knowledge with programmatic and policy implications. His experience includes working both domestically and internationally in implementation science, comparative effectiveness research, and large-scale epidemiologic studies. Dr. Nash has published over 200 scientific articles. His research is primarily funded by NIH, and he brings his seasoned expertise in study design, methodological approaches to large-scale real-world research projects. Dr. Nash has had an esteemed career working at places including at the City University of New York, where he is currently as an epidemic intelligence service officer with the CDC, with the New York City Department of Health, as well as in international programs such as the ICAP program at Columbia University. He has, as I mentioned, extensive global health implementation and research experience. He's mentored over 100 students, both at the master's and doctoral level and postdoc level in epidemiology, public health, and implementation science, and we are very much looking forward to hearing from him this evening. So without further ado, Dr. Nash.
All right, thanks so much, Amanda. It's great to be here and excited to share some of our work. As you heard, we're going to delve into implementation science, and I'm going to try to convey a little bit of the design-related issues that we've encountered and worked with as part of a thread of research around the New York City's Ryan White HIV/AIDS Part A program. So I'll draw some examples from that work for the purposes of the talk. Some disclosures here. And I want to start with acknowledgements first for the work that I'm about to present. The first person I want to acknowledge is Mary Irvine, who's my partner and co-PI at the New York City Department of Health. We both lead this research that I'm about to present. And also the two people, McKaylee Robertson and Rebecca Zimba, I'm going to share a few of their papers. Both of them were epidemiology doctoral students at the time they conducted the work that I'm going to show to you. So a little bit of background. New York's Ryan White Part A program covers about 14,000 people with HIV in the New York City metropolitan area. And the program does have a sort of a supportive service role rather than a medical care role. And those services include things like medical case management, food and nutrition, HIV care coordination, which is going to be the focus of much of my talk today, harm reduction and mental health services, et cetera. And in New York, Ryan White is the payer of last resort in that these clients are not covered for services through other programs for them to be eligible for services. This is a slide, and I'm sorry it's a little blurry. I'm not sure why, but I think I'll be able to convey the message. But it has motivated a lot of our research in the program. On the left, you can see a graph showing retention and care among people living with HIV in New York who are in the Ryan White Part A program and those who are not. And you can see that retention in care is higher among those that are in the Ryan White Part A program. But there's a disconnect as it relates to viral suppression. So despite having higher rates of engagement in care, viral suppression rates are lower in clients in Ryan White Part A compared with those who are not. And that's, in any given year. And then if you look at durable viral suppression, the rates are even, the proportion is even lower. So to us, this noted or highlighted an opportunity for improvement because there is a large group of people who are service engaged, yet not getting to viral suppression. And actually, the New York City Health Department saw opportunities here back in the mid 2000, late 2000, and in 2009 they launched a program called New York City's HIV Care Coordination Program, and it's based in HIV clinics and CBOs that have formal partnerships with HIV primary care providers. It is targeting people with comprehensive medical case management who are sort of vulnerable for poor HIV-related outcomes, and either in a prolonged way or in a time limited way. So that includes people who are newly diagnosed with HIV, people who are currently lost to care or sporadically in care, people who are new to HIV care, or new to HIV treatment, or otherwise struggling with ART adherence, and that includes people with evidence of drug resistance. So, what is the HIV Care Coordination Program in New York City? It is, the figure here in the center kind of gives you a sense of the evidence-based components that make up the Care Coordination Program. It's case management and patient navigation, including accompaniment to appointments by navigators, adherence support with directly observed therapy for those who need it, and structured health education and coaching. And the intensity and focus of these services can really vary depending on the needs of the client and circumstances. And outside of the center figure, you can see the broader activities that support the clients in the program and their engagement. And it's meant to help coordinate the interdisciplinary care team that is supporting the patient. And in terms of who implements the program, it's obviously a client-centered program, but you can see that the people who are involved, the roles of people who are involved in supporting the client. The patient navigator is a community health worker who is the person that has the key player in the multidisciplinary team, and the person that has the most interaction with the clients, and they're responsible for most of the client-facing activities that the care coordination program offers, including things that I mentioned earlier, like outreach and accompaniment, health promotion. And that patient navigator reports to a care coordinator who is responsible for the comprehensive assessments of clients and the overall management of their care plan and interaction with the primary care provider and other healthcare providers. So the health department rolled out in 2009 this program at 28 agencies. At that time, there was no randomization or a comparison group. They just implemented the program, and in December of 2010, they began, after they started implementing, asking questions about what might the effectiveness of the care coordination program model be, and can we assess it? And that's about when they reached out to us to collaborate along these lines. So we did an initial evaluation. We realized this is a very big question, and began applying for NIH grants to support the research. But we also engaged in an initial evaluation with the health department. And as part of this first evaluation, we started with just a comparison of viral suppression outcomes in the year before versus the year after enrollment in the program. And I'll say a little bit about how we did that in a minute. But it's basically, the design here is a pre-post with individual clients as their own controls. And we were looking at viral suppression status on the most recent viral load measurement in the second half of each year. So by that time, by March of 2011, about 3,800 people had enrolled in the care coordination program. Remember, the sort of eligibility criteria were those who may be vulnerable to a poor HIV-related outcome. Ultimately, we were able to include about 3,600 of those in the sample for the analysis for this initial evaluation. So, also design-wise, or a little bit method, here's how we ascertain the outcome, both after they enrolled, but also in the year before enrollment in the program. And by starting with the eShare database, which is the database that includes information on all Ryan White clients in New York, they were able to do a match with this larger circle here of the HIV registry that includes all diagnosed people living with HIV in New York City. And as part of that, it's possible then to identify in the surveillance registry which people living with HIV are also care coordination program clients. And along with that allows the assessment and gathering of longitudinal information on CD4 counts and viral loads, both for those health outcomes and also as proxies for care visits. And in this pre-post analysis, we showed that there were generally improvements in different categories of people that I mentioned earlier on. So among those who were previously diagnosed, this is showing the viral suppression rate before in the year before enrollment and in the year after enrollment. So generally what we're seeing is pretty substantial improvements in this pre-post design. But of course, what the strength of the design is it's using individuals as their own controls, so there's less of a problem of confounding in the comparison. But what this doesn't take into account is secular trends in things like care attendance, viral suppression, and regimens and things like that. So we knew that this, while this was potentially promising, it was also important to think about a design to evaluate this program that included a comparison group. And luckily, we were able to get funding from NIH to support this work, the CORD study, which ran from 2013 to 2019. And what this added basically was, sort of the same idea. We start with people who are care coordination program clients, and we do a match with the registry like we did for the pre-post evaluation. But we're also able to select a comparison group of similar people with HIV that are not exposed to the care coordination program. And so this is an observational effectiveness study. So we're not randomizing here, but we're trying to approximate or simulate a randomized trial or a target trial. And so the way we did that was to sort of assign a pseudo enrollment to. We have enrollment dates for the care coordination clients. These people did not enroll, so we needed to randomly assign a pseudo enrollment date to that group, so we could do a comparison that accounted for this issue of secular trends. So we randomly assigned these dates to people who were eligible for care coordination but who didn't enroll, and then we matched the care coordination clients to the non-care coordination clients based on the propensity for care coordination program enrollment. And these, we could use information that was in the surveillance registry because it was available for both care coordination clients and non-care coordination clients. So these are some of the things that went into our propensity score model and match. And I just want to focus your attention on the left here, which is what the groups look like. These are the people enrolled in care coordination at the time of the study. And these are people in the registry who are eligible for care coordination but did not enroll. So you can see there's a very large number of potential comparison groups of people who could be part of the comparison group. But you also can see that they're very different in a number of characteristics that we measured here, right? And so this highlights the need and the importance of a match. And on the right here, you can see how things look once we selected those groups that were similar. Those people living with HIV who were not in care coordination were eligible for care coordination and also similar on the variables in our propensity score model. Once we did that, we had much more comparable two groups that we could do this sort of observational effectiveness comparison study. Some things that we couldn't match for, but were measured in the care coordination program, but not in the larger surveillance registry. I just want to highlight, some of the major barriers that people in care coordination program are encountering. Unstable housing, mental health functioning, hard drug use. And, if you look across any of these barriers, you can see about 50% have one of these major barriers, we were not able to account for this kind of information directly in our propensity score match. So just want to highlight that. But when we did the comparison, and this is looking at the short-term outcome of viral suppression at the most recent viral load in the 12 months after enrollment in the program, comparing the care coordination program clients to those in usual care, you can see that viral suppression was slightly higher for the care coordination patients. And if you look within different groups, you can see that it was more pronounced in some groups, including newly diagnosed and those with no evidence of viral suppression at the time in the year prior to enrollment in the program, but not so much of an effect in these other groups. We also looked at the outcome of durable viral suppression. I guess one thing before I go there, you can see that the levels of viral suppression overall in this group are on the low side, and they become even lower when you look at durable viral suppression. So small effects on durable viral suppression, which is of course good news, but overall there's not much in the way of durable viral suppression in these clients, and also in the comparison group, people who are not enrolled in care coordination. So what we concluded was there are some short and long-term benefits among some people living with HIV in care coordination program, as well as newly diagnosed individuals, but there remained a lot of room for improvements for reasons I just said. And overall, it suggests a substantial need for sustained and maybe more intensive adherence support in the population. So it also suggests that to enhance the impact of this program, it could potentially be achieved by making some strategic changes to the care coordination program. And there we enter in, the PROMISE study enters, and it's a follow-up study to the care coordination program. And in this study, we had a chance to actually do a randomized comparison, and I'll talk about that design element in just a minute. But learning a lot from both the CORD study and also implementation experience and provider input, the health department decided that it was time to make some changes to the care coordination program, and they made some changes to the design and of the intervention, and issued an RFP for competitive selection of contracts from community-based organizations to implement in subsequent years. In that plan, we were able to convince the health department that even though every organization that wins a contract to implement the new model would ultimately implement it, they would be randomized to either starting early or delayed in this process. And this allowed us to do an RCT where we could assess the impact of these course corrections basically to the already evidence-informed care coordination intervention. And I'll try to highlight a little bit about what some of these revisions were. So these are things that these are components that were added to the model that didn't exist before, and that included things like self-management assessment, the use of video chat tools, for example, for directly observed therapy, and the immediate ART initiation upon enrollment. And these are some of the implementation outcomes that we expected these changes to affect, or these added components. There were some things that were changed. The eligibility criteria was changed to enhance enrollment of people who were really struggling with viral suppression. The payment structure was streamlined, which made it easier for providers. And there was a fair amount of rigidity that both providers and patients felt around the program tracks, which kind of progressively increased or stepped down the level of intensity of the intervention. So these were some of the changes that were made. We did have an implementation science conceptual framework that kind of informed our design and our measurements and our analyses. We used both sort of REAIM and a combination of REAIM and CFAR in this process. And you can see some of our outcomes on the right here. So aim one of the of the study was really a paired step wedge design to compare these two models, the original care coordination model compared to the revised one, and its effects on timely viral suppression. So viral suppression within a few months of enrolling in the care coordination program was the primary outcome. We matched agencies based on things that we knew about them, and then we randomly assigned them to either early phase or late phase implementation. And I guess, here, just to highlight some eligibility criteria, clients had to be newly enrolled in one of these programs, and they had to be virally unsuppressed at the time of enrollment. And also our outcome definition, as I mentioned, they had to be virally suppressed on the latest viral load test reported to surveillance within 4 months following enrollment in the program. So just design here, we had a phase where both programs were implementing the initial version of care coordination, then the early implementers begin for some time period while the late implementers continue to implement the early version of care coordination, and then period 2 where both implementation, both delayed, early and delayed sites are implementing the revised version of care coordination. Unfortunately, we did not see an impact of these enhancements and changes to the initial care coordination program. And actually, this preliminary findings thing is no longer applicable here. I've included the link to our paper in Jade's that describes this RCT. So the first question is well, why didn't we see an effect? And one reason could be that the intervention is not effective. The other reason could be that the implementation of the intervention did not happen as intended. And so we looked at some of our implementation outcomes and began to think about well, what are the factors that changed it from one version to the next that could potentially improve timely viral suppression. And these are the components. And we kind of defined a variable that was was the revised program, was the site implementing a revised version of care coordination, not implementing it all, partially implementing it, or fully implementing the program based on our measures. And when we looked at that, even those sites that were fully implementing the program did not experience or did not show a higher, better outcomes than those sites that were not implementing. So it was a very discouraging result. It appeared that it was just not really moving the needle, despite a very intensive intervention and making these course corrections that were designed to increase the impact. So that's kind of a summary of what we learned early in the PROMISE program. We are in the process of looking at longer term outcomes. Excuse me. It's quite possible that longer term outcomes were impacted while short term outcomes were not. And we're also doing discrete choice experiments with both providers and clients to understand for a future iteration of the care coordination program, what are some of those things, what are some of those components that might be important to think about changing, especially in relation to adherence support. I'm not going to go into these other studies, but there's a suite of other studies that we're doing along these lines. The first one is another stepped wedge trial that is looking at the effect of providing viral load status information to the navigators, which they currently didn't have access to. They kind of either they didn't know what the viral suppression status of the client was, or they would get it maybe by information from the client themselves. And so the question here is, if we provide this information to the supportive service providers, will they be able to better impact, better deliver adherence support services and potentially improve the outcomes of viral suppression? And also, given all this work in the adherence support space, it may be that for some clients, the only thing that might get them moving towards long-term durable viral suppression is long-acting injectable ART type formulations or technologies. And we have an R34 now that is really just trying to understand preferences and acceptability of this, both among providers and clients in the Ryan White program. And what's coming out of it is an intervention design that is going to look like a decision support tool where navigators and clients would sort of go through a menu of adherence support options, one that includes long-acting ART, and then kind of decide what might be best for them given where they're at. So I guess, in terms of design and in terms of our approaches to research, some lessons learned to share here. We learned that the use of surveillance registries as part of the design for outcome ascertainment and for comparison group selection can really increase the rigor of the observational effectiveness studies as well as the RCTs, I'll say. And the experimental design can be implemented in real world contexts. There was a lot of resistance to the idea, but eventually, I think after getting through some of the observational work, realizing some of its limitations and some opportunities, it was possible to do this in a large scale contract environment of the DOH, New York City DOH Ryan White program. And we realized that phasing in, the stepped wedge design is good, where you can look at the phasing in of an intervention. It ensures everyone gets the intervention, but it's just acknowledging the fact that you can't implement everywhere all at once at a large scale, like this program operates in. But of course, there were challenges. Experimental design, not business as usual for a health department. Some of our community partners were definitely not into the idea. It didn't seem ethical to them. And some agencies also didn't like the idea of being randomized. And we capitalized on the timing of the RFA contracts being renewed. And that really helped us in this situation. And lastly, there's not really any low-hanging fruits when it comes to intervention impact in a population of care coordination clients that have really high levels of major barriers to things like ART adherence. So I'll just leave you. We tried to publish a lot of our protocols along the way and a lot of our methods along the way. And so I just want to highlight a few of them here for those of you that may be interested in seeing how we went about doing some of this work. And so I'll stop there. Thanks.
Wonderful. Thank you very much, Dr. Nash. I think that you have highlighted some really great examples of not only the different methods used, but observational effectiveness. I was actually going to ask you after you showed us the care coordination, like, wait, what about the RCT and the step wedge? And voila, there it was. So I think there were a lot of different IS implementation science approaches. So thank you for using that excellent example. And also the importance of working with health departments, surveillance data, community partners, and the various clinics as stakeholders, I think also was really highlighted in your presentation. We probably have time for one quick question if there's a burning one.
I have a combination quick question.
Sure, go ahead, Wallace.
All right, so I kind of include all of I have to say in one long sentence. How about that? I didn't see anything in reference to retention. Thus, it gave me the question, is this study also, is it just a male study? Because I didn't see anything listed as females being a part of it. And this study was also done before COVID. So my question comes back to the word of retention, because that is one of the biggest concerns with Ryan right now, because COVID has changed that process. And then also to the last part, what is the purpose of knowing where people were born? That's my long.
Okay, well, thanks for the questions. We started with people who were already engaged in care. So retention was pretty good. That said, when some people entered into the care coordination program, there was a pretty substantial number lost to the care coordination program that I think is something that the program something that led to some of the changes in the intensity that I mentioned in the redesign of the care coordination program. And as for COVID, I agree. Things have changed a lot. I do think that we were lucky to have implemented the sort of video chat option in this program, because it did come in handy during COVID. As for the foreign-born issue, this is a standard data element that's collected in HIV surveillance, and I'm not exactly sure what it really measures in relation to care coordination program, but our intent was really to take whatever we could from surveillance and try to ensure that the two, when we chose a comparison group, that they were comparable on everything that we measured, and that happened to be one of them, but it was not chosen for any specific reason, except that we had it.
And were females a part of the study?
Oh yeah, so it's the Ryan White program in New York City. So yes, it's a mix. I didn't have a slide that shows it, but the population of people in the Ryan White program is a group of people that are mostly identifies as Black, Hispanic, or Latino, and it's a mix of males and females.
Thank you. I actually do have one other quick question, which is, did you all, or are you going to embark upon doing some type of I guess or an evaluation to try to understand, were there differences in fidelity of implementation? I guess trying to really tease out why you didn't see this statistically significant difference, and trying to understand, is it around the implementation of the intervention? Or is it truly, that the intervention didn't work?
Yeah, I think we answered that question in the Jade's paper. We did look at implementation of the intervention and fidelity, and unfortunately, even taking that into account, we still saw no effect in those sites that were, sort of very true to the model, and really unfortunate. But we think that it's just not working.
Very interesting. Well, thank you for your work and for sharing it with us. And so now I'm going to switch over to Dr. Yamanis. So we have the pleasure of having Dr. Nina Yamanis with us from American University. Dr. Yamanis is the Assistant Dean for Faculty Affairs, and also in the Department of Environment, Development, and Health in the School of International Service at AU. Her research focuses on how social and structural determinants are linked to health disparities, both locally and globally, and she designs community-based interventions to reduce these disparities. She has worked in Tanzania since 2006, and we're going to hear about some of her work there this evening. Her research there focuses on how social networks influence the HIV risk and protective behaviors of young people, and on Tanzania's national COVID-19 response and vaccine rollout. She is an active member of our DC CFAR, and also does research in HIV in the District of Columbia that specifically focuses on HIV prevention for Latino and Latinx immigrants, and is the Associate Director of the Social and Behavioral Sciences Core. I could go on, but I'm going to let her share her experience working in Tanzania and doing implementation science work there.
Thanks, Amanda. It's very kind and very humbling to be in the same room as Dr. Nash. So thank you for the opportunity. I think I'm gonna give a different perspective on implementation science than the one that we heard, in the sense that I'm going to talk more about a context that's less developed, less organized in terms of care, public health care, but also I'm going to focus on HIV prevention, not on treatment. And finally, my work is primarily on vulnerable populations, so reaching those who are not reached usually by prevention programs in Tanzania. So I was asked to just limit the slides to 10. So I'm gonna try to give a brief overview, and then if there are questions, obviously, about any of the methods, please feel free to ask in the Q&A. So just giving us a grounding. I mean, obviously, probably many of us in the room, including some colleagues here who work in Tanzania, know that Africa has the largest population of out-of-school youth in the world, and is the concentration of the HIV epidemic is also there. Many studies have shown that adolescent girls and young women are at increased risk for HIV in East Africa. And those who do not complete high school are twice as likely to be HIV infected as those who finish high school. Nevertheless, many HIV prevention programs, particularly the PEPFAR program, which is the largest scale prevention program in East and Southern Africa, they've mostly reached girls who are in school because they're easier to reach, and just the implementation elements of reaching those who are in school are much easier than reaching those who are out of school. So reaching out of school adolescent girls and young women is a challenge. With this in mind, I just wanted to introduce my team, which is at the Muhimbili University of Health and Allied Sciences, which is the national hospital and school of public health in Tanzania. I have worked with Lusajo Kajula since 2006, and Rema Kilonzo as well. They're both in the Department of Psychiatry and Mental Health. And much of our research together has been on reaching out of school young people through social network strategies. So to give you a little bit of background on Dar es Salaam, which is where we work, well, first of all, Tanzania is a large country on the eastern side of Africa, on the Indian Ocean. It has 67 million people. And Dar es Salaam itself is the commercial capital with 7.7 million people and a 4.7% HIV prevalence. 70% of people live in informal settlements, such as this one pictured here. And there's a large concentration of unemployed youth and migrants. In this setting where heterosexual sex is the main form of transmission, it becomes quite difficult to find people who are at risk for HIV. So our group has used a strategy called PLACE, which involves identifying venues where people meet new sexual partners or engage in risk behaviors, thus identifying venues of risk rather than individuals who are at risk. And so we applied this strategy, this PLACE strategy, to try to identify out of school adolescent girls and young women at the venues where they socialize and the social networks that socialize at those venues. So using the PLACE strategy, we identified 69 social networks in one ward in Dar es Salaam of adolescent girls. Each network averaged about 14 adolescent girls and young women. And they socialized in places like verandas, on abandoned houses, and beauty saloons. We did surveys using funding from NIH for an NIMH R21. We did surveys with 28 networks. 310 of the 383 network members completed those surveys. And 70% of the girls within the adolescent girls and young women age range were out of school. These networks had a high density and transitivity using network analysis, which means that they had high cohesion and are thus very amenable to intervention. We also found through these surveys that there was a high prevalence of self-reported HIV, which was actually quite surprising. So even 15 to 19-year-old girls reported an 8.3% seropositivity, and that just increased with age. We also did qualitative research on the social norms within these networks and found that the norms within the networks supported adolescent girls and young women engaging in transactional sex to alleviate life's hardships. They talked about it as an easy way to earn income without sweating. They also talked about being stigmatized for using condoms and not being able to negotiate because of gender norms in Tanzania. And they recommended economic empowerment interventions to reduce transactional sex. And this is described in a recent publication you can see here. So because they had recommended economic empowerment programs and because members of our group had been involved in evaluating Tanzania's Cash Plus program, we turned to Cash Plus as a potential method for HIV prevention. So what is Cash Plus? Well, many countries in Africa have social protection programs that essentially give cash transfers to young people who are at risk. Tanzania's Cash Plus program includes not just a cash transfer, but also livelihoods enhancement, which means like job skill training and entrepreneurship training, as well as sexual and reproductive health education and access to youth-friendly services. So members of our team had evaluated Cash Plus in Tanzania, which was rolled out in several rural districts for thousands of young people, and found that it actually reduced sexual violence experiences and increased HIV knowledge. So this is our evidence-based intervention. It was not found to influence transactional sex, but the researchers decided that this, strengthening the sexual and reproductive health education around transactional sex could potentially have an impact. So our implementation science aims were to assess the potential for scaling up a Cash Plus and HIV prevention program to social networks of out-of-school adolescent girls and young women. And in the first aim, we just wanted to look at, using the RE-AIM framework, whether financial service providers were able to reach out-of-school adolescent girls with their services. And in the second aim, we assessed the feasibility of delivering a Cash Plus intervention, combining all these pieces and social norms change to 6 networks of out-of-school adolescent girls and young women, using the CFAR framework as a reference. And I just want to say also that this Cash Plus program had mostly been done in rural areas. And so this is the first sort of try of it in an urban area. So what is the RE-AIM framework? This is the picture of it. It's an outcomes-oriented framework, but it helps you identify barriers and facilitators to delivering an evidence-based intervention along several lines: reach, effectiveness, adoption, implementation, and maintenance. So we were just looking at whether or not financial service providers could reach out-of-school adolescent girls using this RE-AIM framework. We did key informant interviews, and many of these interviews kind of reinforced some of the things that we already knew, which was that youth, especially those who are out of school, are definitely difficult to reach because they have limited knowledge of livelihood programs, as well as financial service programs like microfinance and others. In terms of effectiveness, gender norms do not grant women agency to use condoms, but the gender norms also limit sometimes women's accessibility of financial service programs. And there's a societal perception that youth are not reliable. There was a law actually during this time that adolescent girls who became pregnant couldn't go back to school. That was instituted by President Magufuli, who's since passed away. And now that law has been reversed, but many barriers around gender, both for the financial services side and for HIV prevention. So building on this work, we really wanted to see whether we could actually engage out-of-school girls and young women in Cash Plus and HIV prevention. So we did a feasibility study, unfortunately, somewhat interrupted by the pandemic, but we managed to really retain girls over time and continue to interview them as recently as 2023. So we invited 6 social networks of mostly out-of-school adolescent girls and young women who received cash transfer, sexual health, livelihood, and entrepreneurship training, the Cash Plus model. We also had them nominate network leaders to promote social norms change regarding transactional sex, condom use, and livelihoods and economic empowerment. And then we conducted in-depth interviews with 38 participants at 2 different time points after the pilot, including, as I mentioned, in 2023. We used the CFAR to really think about the CFAR is a determinants framework. So we were really looking at, whether this evidence-based intervention of Cash Plus could be adapted for this urban setting. And in particular, we were looking at the characteristics of individuals and the process. So in terms of characteristics of individuals, looking at knowledge and self-efficacy, and then in process, thinking about, whether people were retained in the intervention, and then how did they feel about the intervention. So in terms of our results of the pilot study, we found that in terms of knowledge, which is the participant intervention characteristics, that they felt empowered about their sexual health. As one woman said, now I know how to prevent STIs, how to communicate with my partner and agree on condom use, and how to say no to unsafe sex. In terms of self-efficacy, they felt more financially literate and independent. One woman who was retained over time said that she was living with her mother before the feasibility study, but now I live independently, I pay rent, I support my family. In terms of reach, we had 41 participants, or 72% completed all 12 sessions and 4 boosters. And this is impressive given the urban environment, and these girls, remember, are out of school, being accessed through their social networks. In terms of process, they wanted more boosters, more mentoring and support specifically for the entrepreneurship piece, and increased startup capital. $100 only went so far. And of course, things have gotten even worse with the pandemic and the economic situation that was brought about during the pandemic. So I was asked just to reflect on the challenges and successes. We're now at the point where we're hoping to scale this and look at the efficacy of this approach in terms of both HIV prevention outcomes, but also access to PrEP. But I would say the challenges are certainly vulnerable populations that lacking easy access to those populations via institutions like school. That scalability often can depend on political leadership, and particularly a social protection program like Cash Plus is either endorsed by the president or not. Currently, they have a favorable president, and actually our team has been working with the ministry to improve the Cash Plus program. Our successes have really been, working with local government programs that provide livelihood training and entrepreneurship training. They have been excellent partners and really are eager to scale and implement with us. So that's been wonderful. And I would say also, just as a global health researcher, that these IS constructs about scalability and outer setting, inner setting, and so on fit really well within a health system strengthening framework, which is a very popular model by USAID, but really looks at scalability and processes and how institutions support public health programs. So I really appreciate that part of it, and look forward to hopefully continuing to use IS in our work. So thank you, Asante Sana, and I'll take any questions.
Awesome. Thank you so much, Nina. And we'll open it up to anyone who has questions for Nina, especially as it relates to the study design and how implementation science was utilized in the study. And well, for both Nina and Dennis, but we'll start with Nina because I know Nina has to jump off a little bit early. Go for it, George.
Yeah, first of all, thank you for these presentations. I really appreciate it. I have two questions. Abby, I would like your input on what you thought of the two presentations from a community perspective, because the title was Implementation Science and Community Partnership. So what's your thought with that? And the second one on the two speakers, your input on that community partner, how to build that and what that looked like.
Mm-hmm. Yeah, and George, today's session was, well, all of these sessions are implementation science and community partnerships, but today specifically was also study design. So it's also thinking about how to select some of these implementation science frameworks to design your study. And of course, what's the role that community plays in this work. So go for it, Nina and Dennis, and then I'll share my thoughts.
Yeah, I mean, we do extensive work with the community that I didn't necessarily present just because of time, but we have, when we work in the wards, we work with the village leaders, and we have a youth advisory board who give us input on all parts of the process. And in Tanzania, where every village and actually every 10 houses has a leader, it's actually really important to gain their trust and gain their participation early on. So we've done that for years, and we're very fortunate that they continue to want to work with us. We also really try to invest in communities. Like, so we, for example, when we do our surveys, we renovate the local government office and like do the surveys there, so that we can also give back to the community in that way.
Awesome. Thanks for that, Nina. Dennis?
Sure. So I'll just say, and probably the same is true for your Writing White program, but we have a planning council that has a lot of community representatives on it, and really is sort of part of the process of designing the care coordination program to begin with. And they also had input about some of the evaluation plans, and in particular, you know, the very much interested in the findings at all stages, and so we would receive their feedback and input, and you know, use it to inform the next phase of work. That's also where we got some, but not universal, pushback on the idea of randomization. So it created a good, I think, healthy dialogue around that. In addition to the planning council, though, we're working with CBOs as part of the study, and we have an advisory group of people that are made up of different members of different people working in those CBOs, usually the heads of the care coordination programs themselves. So another way that we get input from community in the process. And I guess if you count the you know, we do extensive focus groups with providers as well as part of the work, and so it's another way that perspective is reflected in our work.
Yeah, and I guess for me, related to George's question, that was one of the questions that I had, was what's the role in integrating, like how much does community engagement play a role in shaping the design of the study? So like what was your process? And you know, so Dennis, you mentioned that you got community pushback on the randomization piece, but how much is community involved in selecting that study design or that framework that you use from implementation science? Nina, Dennis. How much are they educated about it? Because I think what this group is a mix of community members and researchers all trying to learn about what is this implementation science thing. And we recognize the value of community in this process. So yeah, how did you either educate community about IS and then get their input in the design choice?
Yeah, I mean, I don't have a specific example about the study design, except to say that I think economic empowerment programs, particularly for vulnerable youth, are very important, and we are really following their lead on that. Like, I did not, you know, I'm an HIV prevention researcher, but now I'm doing economic empowerment, so that I think that really did come out of the youth themselves wanting that, and the connection between economic empowerment and transactional sex, and just thinking about that context. I do think like transparency is very important with randomization, especially. So we do a lot of work educating the community and the networks about, you know, what does randomization mean? And I do it transparently so that the networks know, like, you're in the control, you're in the intervention. We pick it in front of all the leaders, you know, so pick the groups that are in the control and the intervention, just as a way to improve transparency about the process. But that's in some ways research education, not necessarily related to IS.
Mm-hmm. Thanks so much for that.
Can I just ask a follow-on? So Dennis, you said the community wasn't excited about the idea of the step wedge design, but yet in that design, I don't know, in my estimation, it would almost be better than a cluster randomized trial where not everybody's going to get access to the intervention. So I'm a little surprised that they weren't excited about the fact that eventually everyone will get access to it. But was it just a understanding of what the design meant?
You know, at first that's what I thought it would. First, I want to say that when I say we got pushback, it wasn't a universal from, say, everyone on the planning council. You know, but there were some people who were vocally opposed to the idea of randomization and, you know, experimentation. which, that's how it was viewed by some. And even after, our ethical argument was kind of, we made our ethical arguments. I think I said, it's like, we can't implement everywhere all at once. So we might as well, but we are going to implement everywhere eventually. So we might as well use a design where we can learn something in the process. And so even after hearing those arguments, some people weren't necessarily won over by the argument. So I guess it's hard to get universal buy-in on anything these days. So I'm not troubled by it, and I think there was a healthy dialogue about it, and some of those folks are not on the planning council anymore, but I think it would have been, we usually go back and present the findings as we go, and it would have been interesting to ask questions about so how do you feel about it now that we've learned that in fact there's really not much of a difference in the benefits that people got in one arm or the other. Isn't that important to have learned? And I don't know that it would have helped, but it wasn't universal pushback. I'll just say that.
Thanks so much for that. And so Nina, you mentioned using two models, the CFAR and the RE-AIM. What led you to choose those two of multiple evaluation frameworks and multiple developmental frameworks?
Yeah, we chose RE-AIM at first because we were just interested in, it's an outcomes framework. So thinking about how could these financial service providers that already have products to share with the youth, like microfinance loans, accessing government programs, how could they scale out to out of school girls? How could they better reach this population? So it's less of thinking about adapting this model, but how do we reach more people? And that framework seemed to work really well for that. For the combination cash plus social norms, HIV prevention, we were really adapting this cash plus model that had been done in a rural area to add the social norms component and think of and see how it would work in an urban area. And so for that, the CFAR, which is a determinants framework, which looks at multiple settings, seemed more appropriate for that piece. Yeah.
Okay. And I saw Alan put in the chat that he has an upstream question. Did any of the young women mention access to uniforms or period products as a barrier to school participation or to going to school?
No, they didn't mention those specifically, but only 24 or 26% of young women end up finishing high school in Tanzania. So it's a very low percentage, and it's not unusual, I think, for adolescents and young women in that age to be out of school. And part of the challenge is that they switch from Swahili to English between primary and secondary school. So that's one issue. But I think the other is that, in Dar es Salaam, a lot of people come from rural areas to try to find work in Dar es Salaam. And so there's, a lot of young people who are not in school and who are trying to just make a living. But yeah, it's a good question. And it may have been a barrier for some, but we did not ask.
Alan Johnson, I saw you came on camera. I didn't know if you had a question that you wanted to have.
No. I just had a follow-up question. I really so I'm sorry I missed most of the first presentation, but I really like the entrepreneurship component, especially with youth engagement and CABs. So I was really just excited, especially looking at implementation sciences, because in my former life, that's what I did. To see if you all have any plans for continuances or next steps to support or empower the young women to and expand where they're headed.
Yeah, well, we have applied for an R34 to scale it, to look at the efficacy of this model, particularly for PrEP use. But members of our team continue to work on Cash Plus as a national social protection program in Tanzania. And that Cash Plus model is combined with entrepreneurship and livelihood training. So they've just released the next iteration of their evaluation, which is funded by UNICEF. So it is very important, like I said, because so many young people are not in secondary school, that entrepreneurship and livelihood training is especially important for that age group. So it continues to be a main government program, although of course it doesn't reach everyone, right? So our goal is really to help them think about scalability. But thanks for the question.
Yeah. Dennis, you laid out some lessons that you gained related to utilizing IS in a health department and, utilizing IS with community-based organizations where there is randomization. What advice would you give to groups who are maybe working with a health department, et cetera, on navigating, introducing these types of models or frameworks to study design in active populations receiving services?
So, I mean, I think one of the things that probably contributed to the success of this body of work that we've been involved with is that it was really the health department that approached us with the research question. They didn't call it a research question, but it really was like, does this program is this program effective? And to us, it's a research question, and so we worked with and it was one that was of great interest to us as well. And so I think that alignment, but first and foremost, I mean, the health department's primary role is not a research function. Like they have a different mandate. But if you frame it differently, they do have important questions, important decisions to make that require evidence, and it requires good evidence. And it's also, I think, a shift can happen whereby if the research is aligned with the priorities of the health department and the knowledge they want in order to make better decisions, to make better programs and policies, then I think it can work, and you can kind of get what I think is a shift in a lot of places from health departments thinking of themselves as, consumers of evidence, because they want to have evidence-informed, evidence-based programming and policies. So they've always been consumers of evidence in that regard, but they can also be generators of that evidence. And I think that I think that shift is happening in different places now. It's certainly happened in some quarters in our health department, but it's also really important because health departments are going to be the entities that generate, I think, the most relevant evidence for other health departments. And there's also a shift in sort of this idea of going away from program evaluation, which is, this will help me understand what's going with my program, into one of like, understanding the impact of programs and their effectiveness, such that people outside of their jurisdiction, other health departments might be able to use that information, and that will be reciprocated over the long run. So yeah, we were lucky because they approached us with a research question that was, I think, we thought really interesting and important to try to address. It's harder when you go to the health department and say, we have we're writing an R01 and we want to answer this question. Can we use your STI clinic to recruit patients for this study that I don't even know if you care about it because I haven't asked you, that kind of thing. It's a lot harder.
Thanks a lot. Alan?
Yeah, good evening, both. I know you both well personally and professionally, and I just wanted to ask an educational question rather than a scientific question. You're both known as great educators and professors, and how much when you're in the field doing this work, do you find yourself in in an education mode, a teaching mode, teaching your staff or the community about implementation science techniques? And similarly, how much do you learn about implementation science when you're going through these incredible field studies that you've both done? Thank you.
I'll take a stab first. I mean, one of the reasons I'm in the academia is because of the constant learning that I get to engage in. So I think another really fun thing that I'm lucky to have is that a lot of the collaborators that I have at the health department are like either former students and sometimes current students. So there's a lot of like back and forth between, or I guess overlap between our training programs at CUNY and health department. And that is also really satisfying. And I think I should have mentioned it in the last question. That's part of what contributes to the shift in the culture is the advanced training that some health department employees are getting in I would say implementation research oriented kinds of projects that we and thinking that we instill. So yeah, those are two things, and it's I think it also helps that I've always been very interested in what health departments do and how they do it, how they make decisions. And Alan, oh, I lost you. Oh, there you are. You moved around. I think you had a big role in I think informing the way I think about this. Like a lot of what we do is leveraging surveillance data from the HIV registry and maybe other types of registries, and that's where we met, I believe, at the city health department. And you were a very senior person in the surveillance program there. I learned a ton, and I've been carrying it forward ever since.
Great kudos there, Alan. Thanks for all you do to inspire others as well. Thanks for that, Dennis.
Thank you, Dennis.
And Nina?
Yeah, I would say one of the greatest joys of my career has been seeing my Tanzanian colleagues move forward in their own capacity to do research, and two of them have earned their PhDs since I've known them, and now we are part of a Fogarty Implementation Science Alliance focused on HIV among adolescents. That's for adolescents in Africa, and we get to meet once a year as a group. It's a really amazing alliance, and part of that is to train young people in implementation science and early stage investigators. So we now have a Tanzania alliance that's working with early stage investigators, and we also have a youth board. They attend Ministry of Health and government meetings to give voice to what the youth want to see in terms of HIV programming and implementation of that programming. So it's just been wonderful, that Fogarty Alliance, and I feel very honored to be part of it.
Thank you. It's becoming evident when you both present. You're obviously both wonderful scientists, but it's also your ability to communicate this information. I'm sure your teams, your colleagues, your collaborators, the community you work with is appreciative of the fact that you share not only what you're doing, but how you're doing it, and your personalities come through. And I think that's very impressive. So congratulations to both of you.
Thanks, Alan. Tammy, I saw your hand.
Oh, so can you hear me?
Yes, we can.
Yeah, my internet is going in and out, so I have to turn off the camera. Thanks so much for the presentations. They're really wonderful. I mean, I love implementation science, and I'm actually fairly new. I currently do evaluation, but I know evaluation and implementation science kind of go hand in hand. But this question is more so for Nina. Thanks for the work that you do in Tanzania. For me, when I think about implementation science, I also think about sustainability. I know you talk about scale up the other time, which is great. But for some of those developing countries, like they don't even think about sustainability, even when it comes to HIV prevention. A lot of the grants and fundings for HIV prevention comes from the Western world. So I guess most of my question is around, you talk about the R34. What approach are you looking at in terms of, empowering the community over there around sustainability, because again, if the intervention works, and we've seen that it worked, and now we're talking about scalability. So what happens after that? You know, what happens to more girls that, you know, potentially may be out of school? Like, what happens to them? So is there an approach that you are thinking about to engage the community over there in terms of sustaining this intervention?
Yeah, thank you, Temi. That's a great question. I love that you're love implementation science. I mean, we have really modeled our work on the National Social Protection Program, Ujana Salama. So I think we're really thinking about scalability, like just, they've already done this in 4 rural regions of Tanzania and reached like 10,000 girls. So we're really thinking about like, how can they take what they've already done and continue to do very well in rural areas, and think about how they could apply it to urban areas, to those who are most at risk for HIV, which are out of school adolescent girls and young women. So we're very much thinking about scalability, and members of our team, as I mentioned, have been part of transforming Ujana Salama to make it a better program for adolescent girls. So they've already contributed to some of the changes at the national levels.
Thanks for that, Nina. I know you have to jump soon, so I'm gonna jump in with an interesting question. So I think through Denis's work, we saw that the intervention is showing as not working, right? But there's been resources invested, whether it's HRSA, CDC, you know, different funding that goes into these programs in a very political world, where after you've invested all this money to then have an implementation study say this does not work. How do you navigate that within a health department? How do you navigate and continue to get buy-in in implementation science when you might get results that show that this is not working?
I think that's a great question, and it is, you know, it has been very hard for all of us because we're very, very big believers in this program from the beginning, right? It is not like sort of a low touch intervention that, you know, we somehow magically think is going to impact the viral suppression rates of people who have immense barriers to achieving some of these HIV care outcomes that we are focused on. It is a very resource intensive intervention. It's very evidence informed. It's what is needed. It's not cost effective at all. We did do a cost effective study. I did not expect it to be cost effective, nor should it be. Like, this is, I mean, if you're thinking about ending the HIV epidemic, you know, this is the group that is going to require the most attention to get to some of the milestones that we want to get to over the next several years. And it's not going to be easy or cost effective. I did hope that it would be more effective. And yeah, tremendous amount of resources are being invested in this program. I would say first, we're focused on one very narrow thing, which is like HIV viral suppression and durable viral suppression and HIV care outcomes. But there are lots of other things that this program is likely doing and affecting in very positive ways that aren't necessarily, I mean, we hope that impacting those would in turn benefit, you know, their HIV outcomes. It's not necessarily true in our case so far. And it doesn't mean that the programs are not valuable in what they're doing, you know, from day to day. I think this is really what research is. Like, you really only learn from the failures. And I'm not calling the program a failure just because it didn't show effectiveness, but in order to be able to take the next step and realize that there's a lot more to do, you have to kind of have these intermediate steps that say, well, we're not there yet, and I think that you know, I think that is something that you know, we are beginning to accept and believe in. And also it forced us to think about, okay, well, maybe this paradigm of an intensive intervention that is targeting case management is not enough, and maybe we need to be thinking about long-acting injectables as a potential way forward for some people.
Thanks for that, Dennis. I know Nina has to jump. Thanks, Nina, so much for that.
Thank
If you
you.
have questions, please email her. Email is in the chat. And go ahead, Nina. I saw you unmuted. Sorry.
Oh, sorry. I just want to say thank you and wonderful presenting with you, Dr. Nash, and good to see everyone. Sorry. Good night.
Thank you so much. Dennis, that, what that triggered for me was the importance of that transparency. And I hope our funders of these programs also value the fact that sometimes what comes out of research, even though it's evidence-based, when it gets to the implementation space, it may not necessarily be as effective as what was in a Petri dish, right? And that there should be more investment in implementation science and implementation research in the programmatic space as well, so that funders are more open to that, recognizing that they might learn that it doesn't work. Because I know that there are a number of interventions being implemented that maybe don't work, but we're implementing them because the science said. Alan,
Yeah,
I
think it would be nice too if it was part of the Ryan White program's mission to say, yeah, we're not just gonna fund the implementation and the so-called program evaluation, but we're gonna learn as we go so that we can do better implementation going forward. But it's not part of the culture there yet.
Yeah. Alan, I saw your hand again. Sorry.
What I was going to ask Dennis and Nina, but I can ask Dennis. You both work on both sides of the ocean. You both, any similarities or differences when you do implementation? I actually don't know the answer to this. When you take implementation science programs, approaches and do them domestically versus working globally?
I have to say that there's a lot of synergy that happens for me by working in both places. So some ideas come from working here in the US that I try to bring and explore in other settings around the world, and probably even more so vice versa. And just the idea of even thinking about a stepped wedge at the New York City Health Department definitely came from the things that are happening outside of the US in that space. I probably wouldn't have even thought to suggest or push for it if I didn't see it happening in real world implementation settings outside the US.
I'd love to open it up to anyone else who we maybe have not heard from, who's sitting really silently, who maybe has a question on a study you're designing, or how could we be more involved as community members in IS? Anyone on the call has an additional question?
Yeah, I guess in the interest of time, I'll try to be short, but for Dennis, since you mentioned you were having some, I don't want to say pushback, but disagreements regarding the implementation of where the study would be first implemented, was that a kind of a mismatch to where the community partners thought that the locations being chosen would benefit the most? Because I know you're explaining that we can't implement it everywhere all at once, but that is the eventually the plan. Was some of that kind of disagreement regarding where to implement it first and who would benefit it from the most?
I think it was, I would chalk it up to philosophical differences, as just like, it's more like this kind of science that which some people view as experimentation, and it is an experimental design, right? Was just not compatible with the way some people viewed the health department's role in implementation, the planning council's role, and it was just anathema, and that that's just how it is for some people. I would chalk it up more to philosophical differences, and we even saw some examples where, like at the site level, some sites did not like the idea themselves, and in some instances said that they were going to try to understand aspects of the new program and implement them anyway, even though they weren't randomized. If they find out that they're not randomized to the new model, they're going to try to implement the new model anyway, which of course the health department stepped in and said, no, you can't do that. But there were some differences in opinion about it, for sure. And I think it's philosophical.
Amanda?
Yeah, I just kind of related to that. I mean, I'm thinking about, when we embarked upon TLC Plus in DC and New York, and which was an HIV prevention trial network study that used surveillance as an outcome, surveillance data as, to measure these primary outcomes. And sites were essentially told that they had to participate, I wonder if you can talk a little bit more about it. I think you were getting to it, but this like push-pull between, you're working with the health department, they're funding these clinics to do this work, and yet how much choice do they really have to say yes or no, we want to participate in this, when their hands are a little bit tied because their funding is also associated with this. So,
well, yeah, and not only that, I forget if I said it, but it was explicitly laid out in the RFA that all these organizations applied for. So it's kind of like, I mean, I think there was the organizational level that that they were going after the contract, and then there were the care coordinators that were actually implementing. So they didn't necessarily see the RFA or sign off on this idea, and that was where we would sometimes see some disagreement. But at the organizational level, I mean, they decided to apply for the RFA and they accepted the contract. So the health department always kind of had that, I guess, leverage, for lack of a better word. They didn't have a chance to opt out once they accepted the contracts.
because I mean, you'll never know, right? But, you kind of wonder if the sites that were, yes, let's do this, it doesn't matter if it's in the RFA or not. You kind of wonder if they were, if the implementation would have been different, and maybe the outcomes would have been different. I don't know. You'll never know, but.
Nope. The best we could do was just sort of, I mean, objectively measure how much implementation and of what was happening, and see if those differences, because there were some people who were implementing a less fidelity than others, and if you look at those that were implementing with good fidelity, no effect.
Yeah. Awesome. I'm excited to start using some implementation science to look at some community health worker models across the board. So much of this work, even when there's interventions, these interventions are cushioned within structural factors that affect health outcomes, right? So whether you add a navigator, if you're adding a navigator into a system that's already broken, does that navigator make a difference? Unless you also change the system. So I think there's so many other pieces that we need to measure through implementation lenses, including the system itself. But that's a whole other conversation to be had.
Well, and I would say I didn't have a chance to say this, but that's one of the reasons why we use both CFAR and REAIM, because the CFAR does help you look at those more structural organizational level factors, and I agree, it's very important.
Yeah. So thank you all. 6:59. We used every last drop of our time. Thank you so much, Dennis and Nina, who had to jump off, for all of your expertise. I think as we are learning, this has been phenomenal and a great conversation. So thank you all. And
thank you. Thanks for having us.
Well, it's been a pleasure to have you. And I just want to mention that this was part 2 of our next. Yes, part 2 of 4. Our next session is we're gonna have Dr. Laura Barris from Johns Hopkins, and she's going to be speaking to us about models and frameworks. And we will have a local speaker as well. I'm not sure if that has been.
Julie Pulowitz.
Julie Pulowitz will be our local speaker. So stay tuned, and we will continue this dialogue.
thank you so much.
It was terrific.
Thank you.